Welcome back to the series of videos talking about chest pain. We'll be talking about the differential diagnosis. Now this table summarizes all the different causes. You can take a look at it, but I'll start with a lecture. So pulmonary embolism is the first. Differential patient also comes in with chest pain, but he might come in a hemodynamic instability with hypoxemia, syncope, and shock. Whenever you have a patient who has hypoxia, and with a normal chest x-ray, always have the raised suspicion for a pulmonary embolism. Now there may be associated symptoms or signs like a cough, hemoptysis, and of course signs of DVT, a fever. Risk factors would include someone who's done a previous surgery, someone who is a cancer patient, or taking oral contraceptives, or someone who's had a previous DVT or pulmonary embolism. Now you would of course use the different Wells criteria scores and the Geneva scores and the PERC score, but we'll go over these in a separate lecture. Of course you would also use labs like D-dimer, and a CT pulmonary angio is a definitive way to make the diagnosis. Now, aortic dissection, this one is more of a sudden tearing, knife stabbing pain that starts in the substernal region and radiates towards the back between the interscapular region, and the sudden onset of pain with associated symptoms like central nervous system deficits, like due to the blockage of peripheral arteries that supply certain nerves. So because of the dissection itself, so you might have focal neurological deficits, limb ischemia, and so on. And risk factors for these for aortic dissection would be someone over the age of 50, a male, hypertension, cocaine abuse, and of course connective tissue disorders like Marfan syndrome. And the way of diagnosis would be through a transesophageal echocardiogram, for example, you can diagnose, or a CT aortogram. There would also be elevated troponin levels, and sometimes there are non-specific ECG changes. Pneumonia as well, you would have sharp chest pain, pleuritic in nature, of course with an associated fever because it's a chest or a lung infection, cough with sputum or without, and also hypoxia on oximetry. Once you perform an exam, you would find an area with decreased breath sounds, crepitations, coarse or whatever, and also bronchial sounds, so you would find a gap between inspiration and expiration. And of course the mainstay investigation is of course a chest x-ray. Esophageal rupture, sometimes someone comes in who's perhaps an alcoholic, has frequent vomiting, and after a bout of vomiting he experiences sudden sharp chest pain. So that's a very good hint for the diagnosis. And he would come in with tachycardia, signs of tachycardia, fever, maybe he's gone into sepsis. He can also have shortness of breath, crepitus within the chest, and something called the Hammond's crunch, which is like, it sounds like footsteps on snow. The diagnosis would be made with CT and oral water-soluble contrast. A spontaneous pneumothorax, this one happens when you experience sudden sharp pleuritic chest pain in nature and also associated with shortness of breath. Now there are risk factors for the condition, being a tall, thin male, being a smoker, chronic lung disease like COPD, and also genetic connective tissue disorders like Marfan syndrome. Again, now you would hear on auscultation decreased breath sounds in one area, the affected area, with hyperresonance on percussion. And of course a chest x-ray is the mainstay for diagnosis. Now acute pericarditis is another one, and this one what it's different from the others is the constant nature of pain. It's also sharp pain, sometimes pleuritic, but the constant, it's not progressive, it has this constant nature, and it can also radiate towards the back. It improves with lying forward and worsens with lying flat. You would hear a pericardial rub on auscultation. Of course, you perform the ECG, you see the diffuse ST elevation all over the leads, except the reciprocal ST depression on the AVR lead. And also the PR depression is also present on the majority of leads with a reciprocal PR elevation in AVR. Mitral valve prolapse is mostly a benign condition. Some people have it without even knowing. But if it does cause symptoms, it would also cause palpitations and chest pain with fatigue and shortness of breath. You might hear a mid-systolic click. It's quite difficult to hear, but a very experienced cardiologist will easily find it. Sometimes the pain can be caused by the thoracic cage itself and the muscles. That sort of pain will be sharp, localized, and positional pain. Now, of course, sometimes acute coronary syndrome presents with these features, so we can't rule it out from the nature of the pain. It's also reproducible by palpation, so it can be tender, and increases by inspiration or coughing. It includes costochondritis, which is inflammation of the cartilage of the rib cage at their articulations with the sternum. Xiphodynia is also inflammation of the xiphoid process. Sometimes intractable pain actually leads to the need of the removal of the xiphoid process. Otherwise, painkillers treat many conditions. And something called the precordial catch syndrome, in which there happens to be impingement of the intercostal nerves. Not everyone knows why it happens. It occurs of bouts of 1 to 2 minutes each, and then they disappear, so it's reversible. Risk factors include poor posture and sedentary lifestyle. Pleurisy is another one, and it's due to pleuritic pain from inflammation of the parietal pleura. Gastrointestinal pain is another differential for acute coronary syndrome. And that's because it can also present in the lower chest due to various different conditions. And gastritis or esophageal reflux is one of them. It causes the burning sensation in the lower chest with an acidic taste in the mouth. And of course, it's worse when lying down because of the increased reflux. And ulcer or peptic ulcer is another one. And it awakens you from sleep due to discomfort. And it causes postprandial epigastric pain. So also this region of epigastric region and near the chest. Duodenal ulcers are relieved by eating, while gastric ulcers are exacerbated by a heavy meal. Pancreatitis and biliary diseases, they can also be associated with chest pain, but they present with right upper quadrant pain for biliary diseases or epigastric pain for the pancreatitis. Esophageal spasm, now this one's quite difficult to differentiate from an acute coronary syndrome because it's also relieved by nitroglycerin. However, it's triggered by hot or cold fluids and by certain foods. So yeah, those points in the history might make you suspicion for esophageal spasm higher. Now this one's a hard one, panic disorder or a panic attack. Now, if you look at the criteria for a panic attack, you have to have 4 out of the following. And if you read, you see that the criteria includes palpitations, chest pain, the feeling of fear of dying, and many symptoms that look like an acute coronary syndrome. So that's why 25% of patients with chest pain actually meet the criteria for panic attack, and 9% of them actually end up being diagnosed as acute coronary syndrome. So therefore, do not diagnose panic attack unless you've excluded an acute coronary syndrome. And of course, you always go by history, physical exam, and labs. Make sure to do an ECG. Make sure to do a chest x-ray to exclude different pathologies like pneumonia or tension pneumothorax. And also send for cardio biomarkers. In the next lecture, we'll be talking about troponins and what different conditions other than ischemic heart disease may even raise troponins and how you can manage such conditions. And also, a CT is useful for an aortic dissection or a pulmonary embolism. And thank you for listening.